Hey, everybody. Welcome back to Pulm PEEPs. Thanks for tuning in today. As you've seen, we've been doing a lot of videos, and our episodes are now available wherever you get podcasts, on YouTube, on ViewMedi. So please make sure you like and subscribe us wherever you're hearing this. We're excited to be back with another episode. Kristina, so pumped for this one.
Dave, I know you get so excited. I didn't know if you could get more excited because we just finished our recent pulmonary hypertension guideline series. But when we both saw these guidelines, which we're going to talk about today, are the hot off the press, the brand new 2026 multi-society guidelines for the evaluation and management of acute pulmonary embolism. I was like, Furf is going to be so into this. So really excited that we have the opportunity to do this today.
Yeah, me too. Definitely. All things pulmonary vasculature. I'll take it. And yes, these guidelines when they came out, everyone was talking about them. They're super excited. These were developed jointly by the AHA, ACC, CHEST, ACEP, many other societies together, reflecting really just how multidisciplinary the care of pulmonary embolism has become. And honestly, pulmonary embolism, I feel like we've learned about it, we think about it, it's evolved so much, but we haven't seen new guidelines in a while. So this was very exciting. It involves so many different people in our profession, starting with the initial evaluation in the ED, inpatient management, advanced interventions, long-term follow-up, sometimes in the pulmonary hypertension clinic with me, hopefully not though. And it also often involves multiple specialties. So bringing these groups together really allowed the guideline committee to build recommendations that integrate all these perspectives. And we're excited to talk about it today.
And to help us unpack these guidelines and talk about the thinking behind them, we're really excited and honored today to welcome Dr. Mark Creager. Dr. Creager is a professor of medicine at Dartmouth-Hitchcock Medical Center, where he specializes in cardiovascular medicine with an emphasis on venous thromboembolic disease, and served as a lead author of these guidelines. So Mark, thank you so much for making some time today for joining us, and welcome to your first time on Pulm PEEPs.
Yeah, well, thank you very much, Kristina. Thank you, Dave. That was really a perfect introduction as to why we developed these guidelines and the really impressive nature of our multidisciplinary writing committee, the expertise that was on the committee, and the organizations that are our committee representatives. It is really a multidisciplinary guideline. And I got to give shout out all the credit to the members of the writing committee. It was a terrific group. We came together, and we're all really proud of these guidelines.
Yeah, I'm sure it was a very interesting room to be in. And that's a perfect segue. Our first question is really about the big picture. PE brings, as we just said, clinicians across multiple specialties, multiple venues of care all the time. It's one of the most common diagnoses. I think it's the first diagnosis I learned on the first day of med school because it's so common. So what prompted the development of these new multi-society guidelines? Like, why now? And what gaps in PE care were you hoping to address?
Well, I think it's timely. First of all, it's an important question, but it really is timely for these guidelines to be developed. As your listeners certainly know, there's been significant advances in our understanding of pulmonary embolism and the treatments to effectively manage this condition. There have been other pulmonary embolism or venous thromboembolism guidelines published for years. CHEST has been in this game for a long time. American Society of Hematology, the European Society of Cardiology have all published guidelines related to either venous thromboembolism or pulmonary embolism, but nothing recently. Certainly really not a significant update in the last 5 or 6 years. But also, this is the first clinical practice guideline that was put together by the joint American College of Cardiology, American Heart Association Committee on Practice Guidelines. And this joint committee oversees a lot of practice guidelines in the cardiovascular and cardiopulmonary sphere, but none have been on this particular topic. And what's really nice about the way this committee works is we invite, and when I say we, I mean the AHA and the ACC, invite other organizations that are in the game, relevant to whatever topic is being reviewed, and then guidelines are being developed. So as we've already alluded to, there's a host of representatives right across the board from all types of all the disciplines that are really involved in the management of patients with pulmonary embolism. So now I think we put together a contemporary roadmap to help clinicians navigate the newer advances for the safest and most effective approaches to care for patients with acute PE. And you already alluded to this. We talk about the care setting, what patients can go home from the emergency department, who can be managed as outpatients, which patients require hospitalizations, which patients need critical care. So we try and really cover soup to nuts because the clinical presentation of acute pulmonary embolism really ranges quite broadly.
Yeah, absolutely. And you're so right that there have been guidelines or papers from certain societies, but maybe not ones that are so comprehensive, which reflects a lot of PE care. Anyone who's on a PE response team or a hospital PE team, like I am, knows that there's pulmonologists, cardiologists, interventional radiologists, hematologists, all on this call, emergency doctors. And so everyone should be together represented when we're making guidelines like this.
Absolutely.
So when the writing committee started reviewing the evidence, were there particular areas where the data had really shifted since maybe the prior biggest guidelines or the most in the last few years or the last few decades or two? So
this is really a hot area of clinical research. I mean, basic research as well, but certainly relevant to the guidelines, clinical research. So as you and I have already mentioned, there has been previous guidelines published by, and really excellent guidelines by other organizations, but nothing recently. But there are advances. We have a better understanding of risk assessment, a better understanding of prognosis, a better understanding of who can we send home from the emergency department, who isn't, people who are likely to do well, don't need to be hospitalized, who needs to be in the hospital, who would be best served in a tertiary care hospital, the advantages of a multidisciplinary approach to management for those who have severe presentations, who's going to benefit from advanced therapies, and what should constitute long-term management and follow-up. So I wouldn't say that there's I think what we're doing is building on existing data. We're not changing the data. We just have new information that helps us really discuss what would be the best approach for these patients.
Mark, I love that, kind of building on existing data. And I think you've answered kind of why now. You said so timely, multidisciplinary, a very prevalent diagnosis that so many deal with. I want to shift us into one of the as I was reading this, one of the things that stood out to me most was these new clinical categories for PE. Dave and I did our medicine training at the time when PE was either massive or submassive. I know since then, listeners today have gotten comfortable thinking about PE using, more the low risk, intermediate low, intermediate high, and high risk categories that have evolved over time. But the new guidelines now introduce a new framework, right? It's the A through E clinical categories, as well as some subcategories within those. I'm wondering if you can walk us through why the committee felt this new framework was needed and how you think it improves clinical decision making.
Right. So really important question. I'll preface my remarks by saying I think this is one of the most impactful parts of these guidelines, these new ACCP acute pulmonary embolism clinical categories. You already noted that, when we were training and starting out and managing patients with acute PE, we used what I don't know who initially developed it, but the AHA put out a scientific statement probably about 12, 14 years ago, defining acute PE in terms of whether it's submassive or massive or other. And then the ESC really categorized the clinical risk categorization, as you mentioned, to low risk, intermediate risk, which itself had two categories, low and high intermediate risk and high risk. But it's more complex than that. And I think as we get to see more and more patients with PE, and as we're developing what should be the most effective and safest therapies, we need to drill down a little bit more. And we're particularly talking, I'm going to get into the categorization, but those that had been categorized as high intermediate risk, it's really a much broader group. And to fully understand that group, and those who are even sicker and those who are not sick at all, we thought it would be best to come out with a more detailed categorization to really help us understand how we should be approaching these patients. So if you'll bear with me, I'll run through these AHA, ACC, Acute PE clinical categories. It'll take me a few minutes, but it'll set the stage. So it goes from least sick to most sick. So A is least sick. We call this subclinical. We get called for these all the time. Patient has a chest CT scan because they're being monitored for cancer, and there's a pulmonary embolism there. It's sitting there, and what are we going to do about this? It's an incidental finding. They're not feeling it. We categorize this as subclinical because the patients are asymptomatic. It is an incidental finding. Most of these times, the patients are going to do well in terms of their pulmonary embolism. The comorbid condition is probably a much more serious issue that needs to be dealt with. But for those patients, as we'll discuss possibly later in this podcast, they can typically be sent home from the doctor's office, from the emergency department, if that's where it's done, and don't need to be hospitalized. Category B, these patients are symptomatic, but not very symptomatic, and they have a low clinical severity score. And when you do a CT pulmonary angiogram, you might find some segmental or single or multiple subsegmental pulmonary emboli or non-subsegmental PEs. They're actually also going to do well. And for the most part, these patients also can be sent home. The patients that we all really deal with the most and really require a lot of thought on most effective management are those who are more severely symptomatic. So category C are patients who are symptomatic, but they have an elevated clinical severity score. And we can get into these clinical severity scores a little bit later if you wish. But if they're symptomatic, they're coming in, they have chest pain, they have shortness of breath, they have other symptoms as well, they're at least fitting into category C. And they are if they're hemodynamically stable. And we divided category C into three subcategories, C1, C2, and C3. These align pretty much well with the different intermediate risk categories that we've been talking about. C1, they have normal right ventricular size and function and normal biomarkers such as troponin or proBNP or NT-proBNP. Or they may have an abnormal biomarker with a normal RV or an abnormal RV with normal biomarkers, that's C2, or they have the whole gamut. So they have abnormal RV function and their biomarkers are elevated, and that would be C3. And that latter, as you know, is consistent with the high intermediate risk category that has previously been used. And then we put in another thing called a respiratory modifier. And I would encourage the listeners to really look at our chart to see how we define respiratory modifiers. But basically, it's folks who are having hypoxia and need supplemental oxygen. So that's category C. Category D, we're getting sick. We're calling this incipient cardiopulmonary failure. They may have had transient hypertension, their blood pressure came up, or they have, and this is an area that might require further discussion, normotensive shocks. So, their systolic blood pressure is greater than 90, their mean pressure is greater than 60, but they're showing other evidence of shock. There's end organ dysfunction, elevated creatinine, and particularly an elevated lactic acid. And for category D, we also have respiratory modifiers, whether they're present or not. And the sickest category is category E, which is frank cardiopulmonary failure. These people are in shock. They're hypertensive. They're requiring vasopressor therapy, and that would be category E1. And E2 is the most severely ill. These are folks who have suffered cardiac arrest, and it's refractory or recurrent. They keep arresting. So they're the sickest, and that's E2. And that category also has respiratory modifiers.
Thanks so much.
I hope that made sense, but I'm happy to drill down more.
No, that definitely makes sense. And listeners today will have the link to be able to go to the guidelines directly. We'll definitely put a chart of these new categories, which I think are going to be so important to see. And as you just nicely summarized, Mark, the new system moves away from, the purely hemodynamic labels and instead organizes patients into the 5 clinical categories. And I think it was, as you kind of nicely said or alluded to, it's a kind of a clinical continuum now of clinical severity. And it's really nice if you can see this. When you get to see the graphic of it. I think, speaking for Dave and I who take care of patients in the ICU, we may never see the patients A or B. We definitely see the patients at the right extreme E, but I know many listeners today who may be taking care of patients on inpatient medicine floors, or our hospitalist colleagues that may be taking patients in monitored floor beds, potentially IMCs and ICUs, are going to be more in this gray zone, or the kind of the C to D. I'm wondering if you want to extend a little bit more on how does this framework help us think about those patients who aren't, decompensating, but may still be at risk of deterioration in the coming days, and anything that you'd want to add at this time about the C and D categories.
Right. Great question. So the patients that I think a lot of us worry about, those who are going to deteriorate but haven't when they're being first evaluated, that's really the category C and really category C3, possibly with a respiratory modifier. We're not sure which direction they're going to go, and that's why they absolutely have to be in the hospital. We have to watch them. Whether they initially have to be in an ICU or not, it depends on the actual setting of the institution. But we worry about them, and they need to be watched. And those are people where we really don't have a lot of evidence. Actually, we lack a lot of evidence on what I'm going to talk about in D&E also, but we don't have, particularly for category, what our category C3 is, a lot of evidence to support the use of advanced therapies. I mean, there's studies being done. We'll talk about that a little later in the podcast. But we're still trying to understand the most effective way to manage these patients. Category D, they're sick. I mean, they already have shown evidence that there's a problem. They've had an episode of hypertension, maybe, and fortunately recovered, or they have what we're calling normotensive shock. These are also folks where we're still lacking absolutely good outcome evidence, but we have some evidence to support the use of advanced therapies, whether it's catheter-based thrombolysis, mechanical thrombectomy, or systemic thrombolysis. So these are patients that we're really watching. They need to be in a critical care unit. And these are folks that we're going to be considering the use of some of these advanced therapies, which I hope we talk about later in the podcast. Category E, I mean, these people are the ones that are at highest risk for death, of course. E1, those are folks that, are being treated with systemic lytics, and certainly would be among the group being considered for surgical embolectomy, if that is an option at any particular institution, or other advanced therapies. E2 is really the sickest. They're having refractory cardiac arrest. Those are folks among possibly E1s as well that might be considered for ECMO. So, we're still gathering objective data, clinical outcomes data, which is the most effective therapy, the safest therapy for these patients. But the C3, the Ds, which you're going to be managing in the critical care units, and certainly the Es, those we have to be poised to really pull out all stops to treat them.
Yeah, one thing I really like about this is, at a minimum, it's giving us a really nice shared vocabulary. Because I feel like one of the things that's hard in making the decisions, but then also in reading research papers, is intermediate risk, intermediate high risk. It could have been for multiple reasons. Is this because it's hypoxemic, because we're so concerned about the RV, because of the biomarkers as well? And so it's nice that at least we're subdivided to a point where we can say, okay, well, this is a C2, a patient who clearly falls in the C2 category. And then at least we're being specific about how we talk about them and the vocabulary that we're using.
Absolutely, yeah.
And I think we had talked about now some of what the framework tells us to do once we have the PE diagnosis. But it's even taking a step back, as you mentioned, sometimes there's a lot in incidental PE. Sometimes there's a way that we're actually looking for it. It's high on a differential. Sometimes it's a surprise or it's something we need to rule out. So I want to talk a little bit about how we actually make the diagnosis. When PE is first suspected, what's the best way for clinicians to approach that initial evaluation, and the use of tools like D-dimers or clinical probability scores that I know we talk about so much in the evaluation?
Well, this is where we're doctors. I mean, we're all trained to evaluate patients, taking a careful history and doing an examination. So first and foremost, that's what we're going to do. Typically, if these patients present to the emergency department, sometimes they're presenting to their physician's office. So they really need to really think about what the symptom is and what the clinical presentation is. And we have a number of clinical decision tools to help us really assess whether they are likely or not likely to have a pulmonary embolism. And again, we have a table in the guidelines that really elaborate on each of these tools. That includes, for example, the Wells score, the revised Geneva score, the pulmonary embolism rule-out criteria. They're frequently used to synthesize the history and the physical finding to inform a clinical pretest probability. So if you do that and you use these scores and the clinical probability is low, less than 50%, let's say, it's reasonable, and really we're recommended that a D-dimer is obtained and to see if it's elevated or not elevated. If the D-dimer is low and the clinical probability is low, then we're recommending that folks don't need to go on for imaging. Imaging in terms of CTPA for pulmonary embolism. However, if those two things are not present, but I mean that if the clinical risk score is not low and the D-dimer is elevated, then it's appropriate to go on for imaging.
Yeah, and we're going to talk about that imaging choice and the different modalities discussed, CTPA certainly being the workhorse. And I know sometimes clinicians, even when they think it's low or the low risk score is low, clinicians can struggle with this concern of missing a PE just because it's an important diagnosis. But we're always balancing that with the over imaging. And over imaging is important not only in a systems level, but also for our patients. If we don't think this is a PE and then we find something or we have a different incidental finding, it can be bad for a patient also to have a test that's not appropriate. So wondering if you can comment or if you can say how the committee talked about how clinicians should approach patients who fall into maybe that intermediate category, but maybe one of those things is normal and they want to balance the not missing a PE versus over imaging.
Well, as I mentioned, I think if your history examination and your assessment of a clinical risk score is an intermediate or high probability, you're not going to be comfortable stopping there, right? So you're going to want to go ahead and do some confirmatory rule out imaging. And the same thing with D-dimer. I mean, I know your audience knows that D-dimer is not specific. It's elevated for a number of reasons. But if there's an intermediate risk or a high risk based on the clinical risk score, and particularly if the D-dimer is elevated, we need to move forward with imaging. It's more reassuring if the D-dimer is not elevated, but if your probability is still high, you can't stop there. You're going to need to move forward and get some type of imaging. And I know you're about to ask me what imaging, but I think that my comfort level is if someone doesn't have a high probability and has a low D-dimer, I'm comfortable stopping at that point. Other than that, I think we need to move forward and either rule it in or rule it out.
Thanks, Mark. And that's a really great, I think, perspective and way to see things and make sure we're doing the best thing for our patients. Once we've worked through everything, we've done our history, we've done our exam, we've gone through, we've gotten the D-dimer gotten through some other tools that we can use to really identify where we are and we need to move forward with imaging. I know that this current document and the guidelines say that in most cases, CT pulmonary angiography or CTPA remains a preferred modality for diagnosing PE. I think most listening today, it's widely available, provides a lot of useful information, not only confirming the presence of PE, but helping assess clot burden, RV strain, and I think most importantly too, pointing out are ruling in and out other alternative diagnoses. But that said, CTPA is one imaging modality. For some patients, they may not be able to get CTPA. So I know that these guidelines highlight that VQ scanning remains appropriate, particularly in patients who have contraindications or to contrast or when CTPA isn't feasible. One thing, though, that I noted, newer approaches, and you mentioned this, VQ SPECT can improve diagnostic accuracy compared with traditional VQ imaging. And I'm wondering if you could talk a little bit more about that, VQ, the traditional VQ versus VQ SPECT, and how clinicians should be deciding between imaging modalities in real-world practice.
Thank you, Kristina. Everything you said is completely correct. So I'll just reinforce that. Nowadays, there's a CT scanner next to an emergency room in most places. Certainly the larger hospitals, but community hospitals as well. They have immediate access to a CT scanner. So it is widely available. And it is really the best choice as an imaging modality to diagnose pulmonary embolism. It is better than VQ scanning in terms of its sensitivity and specificity. So if possible, meaning it's available and there is no contraindication to doing a CT pulmonary angiogram, then that's really the way to go. It has really excellent diagnostic performance. And it's not more expensive, maybe less expensive than other modalities. I would even say there are some situations where people would shy away from CTPA, including women who are pregnant. I think with current CT scanners, the radiation dose is lower, and it's certainly something to consider. But when you're comparing the radiation exposure to a CT versus perfusion scintigraphy, you're probably not going to see all that much of a difference. So in most cases, if the CT scanner is available and if the patient doesn't have a contraindication, such as a contrast allergy that can't be dealt with quickly, then I would recommend a CT scan. In situations where there is reluctance, an appropriate reluctance to use a CT, then lung scan is still an excellent choice. I mean, again, we talked earlier about days of old. That's what we did. We were doing a lot of lung scans. I don't think we do many at all anymore, but certainly lung scans were the way to go. But they're not as good as CT. But if one were to do a lung scan, because you can't do a CT scan, it still has reasonable diagnostic accuracy, particularly if it's completely normal. And would be something that would be considered. So then you ask, well, what about dialing that up a little bit and doing a VQ SPECT? Well, studies that have shown compare VQ SPECT to planar VQ scans do show that the VQ SPECT has greater reproducibility and specificity for PE and lower levels of radiation. So if that is available and you're choosing to do a VQ scan, I would pick that.
Don't worry, Mark. The VQ imagers, we in the pulmonary hypertension clinic, we're keeping them busy. We'll keep them active.
Oh, good point. Good point.
But I love your point about the contraindications. I think it's so important about CTPA and really making sure that it's a true contraindication. I think if you have someone in that C or D category and they have a little bit of an AKI, like that should not stop you from getting the CTPA when this is the best tool for the diagnosis. Another interesting point highlighted in the guidelines is the role of echo and echocardiography. So it is not recommended as a diagnostic test for PE, but it obviously plays a very important role once PE has been confirmed in risk stratification. And I know a lot of us are used to using echo or CT imaging for signs of right heart strain. There are different ways to quantify right heart strain on an echocardiography, and they may impact your risk stratification differently. And I'm just hoping you can comment a little bit about how we should interpret right ventricular dysfunction in the setting of a new PE and how that should influence our management decisions.
Great question, Dave. So you're right. First of all, echo is not used as a diagnostic test for pulmonary embolism. It's neither sensitive nor specific. But it does help you with predicting the prognosis of patients with pulmonary embolism. It is an independent predictor for in-hospital death, for 30-day mortality, for clinical deterioration. So as we're trying, and it's part of our clinical categorization, as we talked about earlier. So if someone is diagnosed with a pulmonary embolism, I'm not talking about category A or even B necessarily, but certainly C, D, and E, the assessment of RV function by echocardiography can be incredibly useful. The two things that most people can easily glean from an echo, which is RV size and RV systolic function, they're excellent in being predictive of adverse outcomes. But if you have access to a qualified echocardiographer, I mean, there's parts of the echocardiogram that are used that fine-tune that. So again, I already talked about RV dimension. The RV size is reflecting the RV-LV ratio. But then there's other measures that are used in an echo, the TAPSE, which really measures the distance of the systolic excursion of the right ventricular annulus along the longitudinal plane. That's really good. And if it's abnormal, less than 1.6, that's a adverse prognostic marker. Other things that can be used is tissue Doppler imaging and tricuspid systolic velocity, really to give a handle on the presence of elevated pulmonary artery pressures.
Great. And I know that I feel like that was one of Dave's favorite questions so far. It's like anytime Dave can ask a question about an echo, I feel like his face just lights up.
You know me well, yeah.
We've had a great discussion, though, thus far, though, on kind of the why of the guidelines, the new frameworks, thinking about diagnostic evaluation, imaging modalities. But I think it's a great point to transition to what do we do now as far as management of a PE? Hopefully we'll get to talk about initial guidance as well as, Mark, I know you want to bring up some advanced therapies because I think that's some really interesting and some new information in that. But the guidelines, once a PE is diagnosed, the guidelines have not changed, that anticoagulation remains the cornerstone or standard of initial management. And I think that, Mark, I want you to actually highlight, what are the guidelines and the committee's perspective? What are the most important updates that clinicians should know now about when initiating therapy for a new diagnosis of a PE in an adult patient?
So there's lots to talk about, but I'll try and drill down. First of all, anticoagulation is the mainstay. Of course, there are people in whom anticoagulation is contraindicated, but most patients can take anticoagulants. If they're in category A or B and they're going to go home, you just start them on an oral anticoagulant. Everything's fine. And I would say the same thing with C1 and C2. If you're thinking about advanced therapies, so possibly C3, certainly D and E, then you would probably, and I think most would agree, begin with a parenteral anticoagulant. So we talk about that in the guidelines, and then we go into which parenteral anticoagulant should be used. And really, I'm referring to unfractionated heparin versus low molecular weight heparin. And there was considerable discussion about this issue. We made a recommendation based on a review of the evidence in the literature, but I think in many places people have been using unfractionated heparin because they're concerned that a longer-acting heparin, low molecular weight heparin, may limit their ability to do other things and if they needed to stop it, and it's easier to stop unfractionated heparin. But the truth of the matter is, it's hard to use unfractionated heparin. Everybody knows this. Really, to get it started, make sure you get into a therapeutic level. Maintaining a therapeutic level is difficult, and there's a lot of highs and lows in the ability of unfractionated heparin to get to a therapeutic level. So, we were recommending, and we do recommend them, low molecular weight heparin. It's a much more steady state, much more. It's easier to use, and there's data to support that. For example, there's a meta-analysis that shows that low molecular weight heparin reduces VTE risk more effectively than unfractionated heparin without increasing major bleeding risk in patients with acute PE. As I mentioned, it has predictable pharmacokinetics. You don't have to do routine monitoring. And it's also associated with a lower incidence of heparin-induced thrombocytopenia. So given its convenience, relative safety, and efficacy, we came down on the side of using low molecular weight heparin. And I think that will create discomfort for some people, but I'm hoping more and more folks adopt that.
Yeah. And this is, we've already covered some huge points, but for everyone listening, a huge thing to know is you should be using low, or the guidelines are now recommending low molecular weight heparin in general for patients with new PE. And if you haven't been involved in a case where unfractionated heparin has been used and didn't get therapeutic quick enough, and I'll tell you, it's rough. I think these happen all the time. So many of you may have been involved where there's a PE, they get started on heparin, but then something happens and you realize they weren't therapeutic in the first 6 hours and everyone feels really terrible about that.
Exactly.
So hopefully will help that. So moving forward with our treatment discussion, I think one of the biggest areas over the last few years or many years has been this discussion of advanced therapies, catheter-directed therapies, which we're not going to be able to get into all the details, but our listeners should know, just saying catheter-directed therapies, there's a huge gamut of what those therapies are. So we can't cover every specific, but in general, this big question of catheter-directed therapies versus some version of systemic lysis for patients who are in that C3DE category is this huge question that comes up all the time about what's right for the patients. And I think everyone was really flipping to that section of the guidelines when they came out. So Mark, hoping you can discuss what the committee's approach was to making recommendations about catheter-directed interventions.
This was one of the more exciting discussions we had when we put this document together. It's exciting because we don't have enough data. So there's a lot of discussion based on experience and the available data that's out there. So for the categories we mentioned, and we do have a chart in the guidelines. So as Kristina mentioned earlier, please take a look at these guidelines. It really summarizes our thoughts on advanced therapies. And, I'll put them into really 4 buckets: systemic thrombolysis, catheter-based thrombolysis, mechanical thrombectomy, and surgical embolectomy. So the data we have so far, which is reasonable, doesn't include hard outcomes. What we have is studies that have compared traditional anticoagulant therapy to for example, a catheter-based intervention or to systemic lysis. And for the most part, what we found, not what I found, but what has been reported in the literature, is that short-term measures such as the RV-LV ratio or hemodynamics improve with catheter-based interventions. But whether the long-term outcomes, and particularly mortality, in some cases morbidity, whether that's favorably affected by these advanced therapies is less clear. So again, I think your listeners will be familiar with previous studies, whether it's Ultima, Optimize PE, Sunset, Canary Storm PE, which is relatively recent, suggesting favorable short-term measures. Again, the ones I've mentioned, but it really hasn't been translated yet into whether these will improve outcomes, hard outcomes. So we were very cautious in our recommendations, and given the current literature, we, for the most part, give 2B recommendations. So just to remind your listener, a 2B recommendation it's not hard. It's not a strong recommendation. We use verbiage like you can consider doing this, our strong recommendations, which were our class 1 is do it. It's recommended. Class 2A, it's reasonable to do it. 2B is you should consider doing it. So it's not a stronger recommendation because we don't have the enough sufficient outcome data to give a higher level recommendation. But as we'll talk about, I hope in a minute, there's more coming down the pike. But so for all the 4 things I mentioned, or at least for the systemic lysis, catheter-based thrombolysis, and mechanical thrombectomy, we're giving 2B recommendations for C3. We're giving 2B recommendations for D1 and D2. And we also give a 2B recommendation for surgical embolectomy for D1 and D2. And for E1, we've dialed it up to, because these people are really sick, 2A recommendations across the board for all of these advanced therapies.
Yeah. And so much is going to depend on what you have available and how quickly you can activate some of these things. So I think we'll still have to have a lot of discussion about those patients. But I want to dive into this was the group of experts for this field. And you mentioned that there may be data coming down the pike. And I think everyone's looking forward to this. So what should we be keeping our antenna up for about which ongoing trials or new data in the coming years do you think will influence the next guidelines?
Well, the new data is definitely going to influence the guidelines. I don't know which way yet because I don't know the outcomes.
Yeah.
But yes, we'll be able to have much firmer recommendations once these clinical trials come out. So there's at least half a dozen that I know about. HiPytho, which is comparing catheter-based thrombolysis to anticoagulant therapy with a 7-day outcome, including PE-related death or decompensation. That's going to be reported out at the American College of Cardiology meeting at the end of this month. So that one we'll know. Others that are in the pike and should be reported out soon is Peerless 2. And then there's also PE Tract, Persevere, Torpedo, Prague, and they're either looking at catheter-based thrombolysis or mechanical thrombectomy versus anticoagulations. PE Tract is comparing catheter-based thrombolysis versus mechanical thrombectomy. This is an exciting time. Of course, we couldn't wait to write the guidelines for all these things to come out, but we'll do an update once they do.
So many great names for these upcoming studies. But Mark, you bring up a great point. So many things that we can do now for that are now available for patients, specifically those in category D and E. And I know many institutions now have PE response teams or PERT teams, and this is something that specifically you and the committee address in these guidelines. But I'm wondering if you could talk a little bit more, what was the committee thinking about the role of PERT teams when it comes to managing patients with higher risk PE? And I think a follow-up question for that, I know that PERT teams are available at a lot of institutions, but what about at institutions where a PERT team's not available? How should clinicians be able to manage these higher risk PEs as they think through making the best decisions for these patients?
Well, Kristina, great question. And this is really part of what we spent a lot of time talking about. So pulmonary embolism response teams have been around for probably about 15 or more years now. It was initially developed at Massachusetts General Hospital and really took off. And there's a whole PERT, that's the acronym, consortium now. As we talked about at the very beginning of this podcast, there's a lot of different disciplines that are involved in the care of pulmonary embolism. And in one institution, there may be one discipline which is really taking the lead. Another institution might be another discipline. But this is really an opportunity for multiple experts to get together to really think about cases and do it soon. As soon as the diagnosis is made, particularly in those who may have certainly D and E categories and even C3 or the other C categories. Really get their heads together. What do we know? How's the patient doing? And what would be the most effective and safest approach to any particular patient? So, clearly in large academic centers, you have critical care folks like yourself, cardiologists, general cardiologists, interventional cardiologists. I'm a cardiologist. I also do vascular medicine. So there's places with vascular specialists who are involved. emergency medicine, hematology, oncology, pulmonary, cardiac surgery, pharmacy, nursing, interventional radiology. I'm sure I'm leaving out a group, and I'm sorry, but all these folks, depending on the institution, are knowledgeable and very helpful in moving forward with the most effective management of patients with severe pulmonary embolism. Now, I'm not saying that 8-10 people need to get together every time a patient with a pulmonary embolism comes in, but there should be some coordinated effort among multiple disciplines if they are available, if the expertise is available at a particular institution. And it's been shown that PERT teams do certainly reduce hospitalization, length of stay. It's less clear whether it has a favorable effect on long-term mortality, but the short-term management has certainly been favorably affected by these PERT teams. So what happens if the patient's not at a tertiary hospital, they're in a community hospital or even a critical access hospital? You don't have this. You don't have all these resources. So a PERT team will not necessarily be put together there. They can't. But there are consultations available at larger hospitals, and certainly there are connections, networking that's available to any physician, emergency room physician in particular, at a smaller hospital or a hospitalist at a smaller hospital who needs additional advice. So I would say there's places it can't be done because they don't have the resources. There are places where it is being done, such as at the larger hospitals. But if you do have these folks at a hospital, but have not yet formed a PERT team, we're encouraging that be done. These really make a difference. And, we all work together. We're working together to improve the care of our patients. This is not a competition. This is how we effectively play together in the sandbox, keeping our eye on the goal, which is our patient and the patient's outcome.
This has been a great discussion. I think we have time for one last question. And I wanted to talk about the follow-up after a patient gets through the acute phase of PE. This is an area that's near and dear to my heart. I'm taking care of CTEP patients. I never want to miss a patient that gets CTEP. Thankfully, most patients with PE don't end up with CTEP. But Mark, I was hoping you could tell us what the guidelines recommend in terms of post-PE follow-up and longer-term management.
So they're critically important. First, I'll say this is a guideline on the management of acute PE. We don't get into management of folks with CTEP, but we do talk about following these patients and knowing what to do if they have clinical findings suggestive of chronic thromboembolic pulmonary disease and CTEP in particular. So I begin by saying persons in the emergency room, they're in the hospital, they're in a service, maybe there's a hospitalist managing that service. They're started on anticoagulants, they're sent home. Somebody's got to see them. You just can't leave them out in the wilderness. So we recommend that at least within the first week of discharge, somebody talk to the patient, not necessarily a patient visit, some type of communication, just to make sure the patient understands what happens, understands what a pulmonary embolism is, has been placed on therapy, and knows the therapy that they're on, and they're taking it. And to ask safety questions, for example, about bleeding. So we recommend an early communication with the patient. Then we think the patient needs to be have an eyes-on visit at or before 3 months following the diagnosis. Again, review how things are going, see how the patient's feeling, assess for persistent PE symptoms, decide whether any additional testing is needed. Again, maybe there's a consideration of risk factors for PE that haven't been addressed in the hospital, things of that nature. And then to discuss the duration of anticoagulation. And again, I know we didn't get into that today, but we have a extended section on what patients can get 3 to 6 months of anticoagulation, who should get extended duration anticoagulation. And then we're moving into your area of expertise, and that is what patients who have persistent symptoms. And as you mentioned, many do have persistent symptoms after PE, and some of them will go on to develop CTEPD or CTEPH in particular. You need to know about that and decide how to best move forward with them. We do recommend that once you're considering CTEPD, you send them to someone who knows really how to best manage these patients, like yourself, Dave. But that's the purpose of continuing to follow these patients who are continually symptomatic. And then for those who are on extended anticoagulation, we recommend periodic reassessment to see how they're doing. That can be done by a specialist, or certainly if the primary care physician is comfortable with the patient's primary care physician.
Wonderful, Mark, and such a great discussion that we've had today. I wanted to just highlight a few of the key points. Again, everyone listening today will have the link to the guidelines. Notice some of the charts that you'll also be able to see. But things that I'm still thinking about and taking away are the new guidelines introduce 5 acute PE clinical categories A through E, thinking of a severity continuum that really help guide treatment decisions. Diagnosis begins with clinical probability assessment, including D-dimer and other risk tools that you can use. CTPA remains a primary imaging test. DOACs are preferred anticoagulation over vitamin K antagonists. And I think one hopefully big takeaway, I'm sure, Mark, that you and the committee want listeners to know, low molecular weight heparin is generally preferred over unfractionated heparin now. Advanced therapy should be considered in patients with clinical decompensation or cardiopulmonary failure. And then you just nicely discussed how important follow-up after PE is crucial and critical. But as listening today, we've covered so much and such a great, so honored to have you on join us today, Mark. But if you had one key takeaway from these new guidelines for listeners to remember for when caring for patients with an acute PE, what would that be today?
Well, first of all, Dave and Kristina, thank you so much for having me on today. It was really a pleasure. And I do hope the audience has learned some new information. But most importantly, I want them to read the guidelines. It doesn't have to be a cover-to-cover read, but really become familiar with the recommendations. There's pocket versions available that you can keep on your person to refer to quickly. I can't say there's one key takeaway. I mean, one of the newest things, of course, are the clinical categories that we discussed. So I'd like people to start thinking about them and using them in their descriptions of the patients they're taking care of. But really, all the things that are in the guidelines are really so important as we manage our patients. So understanding clinical risk assessment, understanding acute management, understanding who can go home, who can stay in the hospital, understanding who might be benefiting from advanced therapies and the long-term follow-up. All these are important, and I think nicely laid out in our guideline document.
Thank you so much, Mark, for coming on the show. This was a great episode. Thank you all for listening. We appreciate you tuning in. This episode was written and produced by myself and Kristina Montemayor. It was edited by Dr. Dustin Latimer. You may have seen some graphics if you're watching on video. Some of these were produced by student Dr. Riley Scher, and the music's original music by Eric Rogers. And we'll see you next time.